Professor Stephen Lawrence. Oh, there we go. So we're going to record the session and we will send it to everyone afterwards. But delighted to be joined by Professor Stephen Lawrence from the University of Warwick and Kenny Clark, who is a doctor in Australia and currently on the programme. So Kenny, actually, if I kick off with you first of all, tell me a little bit about diabetes in Australia. How much of a challenge is it?
Oh, thanks, Darren. So yeah, the diabetic landscape in Australia is very similar to the UK. We've got the 5% officially of people with diabetes and the prevalence, but we really know that it's a lot more. And as a GP myself, I'm finding more and more patients are becoming diabetic. And we really need to start being more at the coalface and trying to reduce this prevalence with our patients that we come in contact with. And I think as doctors and GPs, this course is great for me because it's certainly making an impact in my patient management and also understanding the evidence behind why we're telling the patients to do what we want them to do.
I think that's probably the ultimate aim of any program like this is exactly that, to impact on patient management, and to, as you say, to understand what the latest research is saying and how that should influence how we go about helping patients. But it strikes me, Kenny, if I look at kind of Australia versus the UK, am I right in thinking there's a lot more challenges with Indigenous populations, with rural medicine? Does that play into diabetes more than it would have in the UK for you?
I've trained in the UK and I'm now in Australia for 15 years now. The Indigenous health question is a very hard one to answer. Certainly the prevalence is a lot higher. The complication rates are a lot higher in the Indigenous population, and the compliance rates are very difficult to get your head around how you solve it. Yeah. And as a doctor, I don't know what the right answer is to help reduce that sort of burden in the Indigenous population. The distances are certainly huge. My patients alone, they don't think a 6-hour drive to come to the doctors is a big deal. That's what happens. And they're accepting that if they have a major event, an MI or something, then that's the decision. Help won't be close by. And as a GP in Australia, you're really quite friendly with the fax machines, sending things off to various pharmacies, and there's lots of outreach clinics. So there's a lot more telehealth and coordinating care. But also I think the level of resources in Australia is superior to the UK. I think GPs have got access easily to pathology, radiology, specialists. There's more specialists in Australia than GPs. So I think that we've got lots of good things, but certainly the Indigenous populations are a really hard thing to nut down and try and improve, I think.
Yeah, no, I think you're right. And Stephen, jump in with any of this as we chat. I mean, one of the, sorry, Stephen.
Yeah, absolutely. And it's really interesting to hear Kenny's viewpoint, because what we tend to find is that irrespective of where you are in the world as a healthcare professional, the challenges that you have with regards to managing diabetes in people who are at any course of that pathway, right from pre-diabetes through to developing complications, the challenges are very similar. We have populations where people are engaging. We have here in the UK hard to reach populations, and the differences when I've visited different parts of the world and you speak to healthcare professionals, the differences between the challenges for me here in the UK and say people in Malaysia or Australia or Dubai are really the nuances, the differences that come down to culture, that come down to the systems with which you work. But the challenges, surprisingly, are very similar. And one of the advantages of, I think, of this course is that we do actually delve down into those important differences, because your teaching and your learning needs to be adapted to the person in front of you, the person with diabetes. We talk about this individualized approach, and that has to really be at the helm of our management strategy.
Yeah, no, completely agree, Stephen. And you know, as you say, there are regional differences, but we see the same issue cropping up in terms of, you know, lifestyle modification, diet, exercise in London, Dubai, and Sydney. You know, it's there are some constants in this. But Kenny, talk to me. You're a busy clinician, with a large and very varied patient load. How have you found studying on a postgraduate program part time and online? How has it gone?
Well, I was just thinking before we came online, what it's just flown by, and I was thinking it's been 9 years since I fellowed as a GP, and I haven't really done anything postgraduate. I've worked, I've got a business started, family started, and now I was like, I really got to, get something else, and I wasn't confident in my knowledge in regards to diabetes management, and then so the prospect of going back to university, I couldn't see where I could fit it in. Like, no way. But I was just thinking, we've been doing it for nearly a year now, and it's online learning. It's been so convenient for me. I've gone to work, come home and do my parents' thing, and once the kids are in bed, I'll jump on my phone and I'll do my my online learning for an hour every night, and then the tutorials every week on Thursdays is the part where you really put it all together, and then you've got these 6 modules that are like 5 and 6 weeks long each, and I just look back and like I'm just really confident now in terms of the evidence behind my learning and how I can, really influence my clinical practice. And it hasn't impacted my life in any way, like my other responsibilities.
And that to us is, when we designed this program, it was designed from the outset to be an online offering, and I think that bit it is brilliant to hear. Anytime we chat to people about it, and it's funny. So you're doing a piece every night. Other people will do kind of a clump where they'll say, I'll do a Sunday morning or a Tuesday evening or whatever suits them. But I think the ability to manage it with small family, busy clinical load is exactly what it was designed for, and that's one of the things we're most proud of, is that through the pandemic, like the people that started in your group, they started a program at the very start of a pandemic, and have managed to get through it fine. We've seen not much difference in engagement rates or in pass rates. It astonishes me that I suppose the degree to which people have actually wanted to be distracted by something other than COVID and talk about something other than COVID. And I suppose the last piece, and I'm conscious of time and kind of moving on to the other sections, but how did you find you've spoken a lot about the kind of evidence base. How did you find the essay writing, the academic piece of it?
Oh yeah, that was my biggest worry, was trying to. I couldn't remember how to write references, and and that was, I was worried about. God, I'm gonna have to write. When you were a student and you were pre-med, you were worried about your assignments, but this is another level. You're now a doctor. You're meant to write good assignments, and I was like, I can't even remember how to do references. But the module, and especially I've learned it on my phone, the module in the course like website is just on my phone, and it's superb. All the resources are just in the palm of my hand. The support from you guys in terms of, this is how you do essay writing at the start. This is how we look at research. I wasn't embarrassed to ask questions that I thought might be silly, and I was taken in at the very right level for me to say, this is what we look at evidence. This is how you write in essays. And the essays themselves were pitched at the right level for me as well. And I really got a lot out of the essays at the end of each module, because that's where I really, made it concrete inside my own memory and knew that I knew it.
It's brilliant to hear that, Kenny, because our hope is that what the essay is doing is asking you to look at the evidence base behind something and then draw it all together and be able to critique it. And it should always have like practical clinical focus as well. So it's I think the type of assessment, we'll speak about it later on, but the type of assessment in the program, it's designed so that, yes, we need to be sure that you've got the evidence base and that you can critique literature, but also that you can apply this clinically. It's not a purely academic program. It needs to have that real life clinical perspective. But if I was to ask one last question, what advice would you have to somebody who's thinking of coming onto the program? How would you approach it now, with all the benefit of hindsight? What would you do in the first couple of weeks?
I don't know. I think it's honestly, it's been really. I don't think there's been a downside. I don't know. I don't think there is anything I would have done differently. I'm happy with the level of work that needs to be done. I'm happy with the way that it's been delivered. I'm happy with the resources. And it's really flexible as well. If I needed an extension because of the COVID run out in my clinic, and there was no hassle at all. And at the end of the day, I'm hoping to get a master's in 6 months, which I never thought a year ago I'd ever be close to. And it's something that I feel happy that I've got something behind me, that I've got an extra string in my bow now, that as a GP moving forward in my career, that I think it's going to be really useful.
Yeah, and in fact, if I can just interject very briefly, Kenny, I think that's really important, because as you've said, it's a career boost. It's something that you feel will actually enhance not just your medical knowledge, your clinical knowledge, but your career. In terms of your knowledge base before you started on the course, because as GPs, we are expected to be generalists, aren't we? We're expected to show a breadth of knowledge. But in terms of your depth of knowledge in terms of diabetes, how do you think that has changed over the period of the course? And has that change altered the way in which you practice?
Oh yeah, before I started, as GPs, we go to, drug lunches and dinners and conferences, and you kind of learn through osmosis, and you think you kind of know, but you're really just learning through other people's opinions, I think. And with this course, with formal teaching, you're taught the evidence that has shaped medical care in diabetes from, the 1980s onwards. And, it's made me really confident in not just diabetes care, it's cardiovascular care, it's pregnancy care, it's, cultural care of people with different religious backgrounds with diabetes. It's everything. It's not just about sugar. And I've started saying to my patients, stop looking at yourself as a diabetic. You're someone who's at high risk of a heart attack and stroke who happens to have a problem with sugar. And that's the biggest thing was, I knew it was important about blood pressure and cholesterol, but I really didn't know where all that evidence came from. But now I'm really confident. I know the journals, I know how to look at them, and I know that it's very important to look at someone's, cardiovascular risk, not just sugar. And that's my biggest change is it's not just sugar anymore. It's a lot more.
Brilliant, brilliant. Look, Kenny, thank you so much. Stephen, I'm conscious of times. You know, the three of us, I think, could chat about this happily all evening. Stephen, do you want to go through your talk now, or will I do the piece? Which would you prefer?
So I'm happy for you to do your piece. In fact, the backdrop is really just to give interested delegates around basically a flavour of the kind of thing that we discuss and the style. We all have different ways of actually presenting, and on a weekly tutorial basis, you'll have the chance to meet with your tutor, and you will have a similar kind of setup to what I have now. It may differ in style, it may differ in approach, but if I just basically go through, it won't be any more than 3 or 4 slides just to give you a flavour of the kind of things that we look at. So as Kenny has just alluded to, we know that diabetes is associated with a whole host of complications, and typically we break these down into the small vessel disease, the microvascular complications that you can see there on your left, and the large vessel disease, the macrovascular complications. And at this point, I would normally throw out a question to the group and say, well, look, you know, if you had diabetes, if I've been generous enough to give you a diagnosis of diabetes and you have to choose one complication, you know, one group of complications, would you choose to have a microvascular complication, a small vessel disease, or a large vessel disease? And it's interesting how people then make their choices, because they then justify why they make those choices. Some people may say, well, I want small vessel disease because I know I'm not going to die from that. A macrovascular condition like a stroke or heart disease is likely to be life-limiting. Then others may say, well, okay, well, a microvascular disease will alter your quality of life. You know, diabetic retinopathy is not a problem if it's background retinopathy, but if you have proliferative retinopathy, you've needed laser treatment, you've got sight limiting pathology, then that's quite a different scenario. So again, these different kind of situations help people to understand how diabetes is affecting patients, how it impacts on their livelihoods and on their longevity of living. In addition to this, we often then look at aspects of treatment criteria. So the new consensus, the EASD ADA, so the European Symposium for the Study of Diabetes and the American Diabetes Association, they've brought out a consensus. It's now quite old, actually. It was 2018. Yes. And that has completely changed the platform, the way in which we treat people with diabetes from a pharmacological point of view, looking at whether there's existing atherosclerotic cardiovascular disease, as you see here in the grey, or whether they have chronic kidney disease, or whether there's heart failure, and decisions are made at a very early stage beyond metformin on that basis. You will also, and I won't transition through the slides just because it will take up too much time, but if we look at the very beginning of the course, you'll be exploring aspects of lifestyle, what causes someone to develop diabetes, what is pre-diabetes or non-diabetic hyperglycemia, and then case scenarios will be used to illustrate the principles. So this is not just about conveying facts to you in a very one-way didactic approach. It's very much a dialogue that takes place in the tutorial sessions, and it's very systematic and ordered, going from lifestyle management through to the diagnosis of diabetes, through to the treatment of diabetes, complications, special cases, as we go through each level of the course. So it's difficult to put it into just a few minutes, but hopefully that gives you a flavour of the kind of things that we discuss. But I look forward to certainly welcoming you onto the course and to engaging in some of these kind of discussions. I'll just finally say that my role at the University of Warwick, yes, I take part in the tutorial sessions, But my role is really around ensuring that there is a level playing field, that there's quality maintained for the course, so that anyone who actually embarks on the course has an equal chance, every person has an equal chance of actually matriculating, of qualifying at the end. And as Dermot will show you later on, by far the majority of people do very, very well on this course.
Yeah, absolutely, Stephen. I couldn't agree more. I think the focus is hopefully what people are seeing is we're trying to strike that balance between looking in depth at the evidence and then being able to apply that so you get real clinical benefit. But what I'm going to do now is I'm going to share screen over here and walk you through.
As you're setting up, sorry for interrupting. Just as you're setting up there, I know an awful lot of our Australian participants on the webinar and clinicians kind of ask and scratch their heads going, wow, we've some of the top universities in the world in Australia and extremely highly ranked. So why would we do a UK qualification from halfway across the world? And I think that's just a very valid question that needs to be addressed. One of the reasons why we do promote this program in Australia is that we had a high number of inquiries before we even advertised in the region. And when we looked into it, there's a huge amount and wonderful amount of diabetes educator programs that are excellent. But actually, in terms of an interprofessional qualification beyond nurses that incorporates GPs and pharmacists and the wider integrated care and transmural care team group, there's actually a deficit of that type of masters in Australia. So one that incorporates the whole clinician community. So interprofessional education is one of the reasons why we looked at Australia. And we were getting sign-ups and registrations without ever making any effort. So that's one of the main reasons. And I think another kind of advantage to doing this program in Australia is that you're exposed to not only local academics, and one of our lead academics, which Dermot will show you now, is Ralph, and he is Ralph Audehm. He is the head of the Primary Care Diabetes Society in Australia, and he saw quite a gap or a need for this type of qualification within his GP community. And also you get exposed to a global taste and a global experience with a mix of clinicians from around the world, which really, I think, broadens your peer-to-peer learning. So I'll stop there.
All valid. And I think Kenny is going to shoot off in a minute. So I just want to acknowledge his contribution and say thanks a million for joining us this evening, Kenny.
Thank you so much.
Yeah, you certainly at this stage don't need to listen to the structure of this program and what it's all about. So I suppose one of the things that you'll see and hear quite frequently about the program is you're going to see IHEED mentioned in conjunction with the University of Warwick. And actually, we're an Irish company. We are part of the Cambridge Education Group in the UK. But what we've been doing since 2014 is really working with health ministries and health regulators across the Middle East, Europe, and into Malaysia, actually, on family medicine capacity building. So we've got a number of family medicine residency programs. We also have a number of postgraduate qualifications. So all that we do is online healthcare education, and we've become somewhat proficient at it. It is effectively we're enabling institutions like Warwick, like the College of Physicians, to bring their programs to a global audience. And I think, it never in a time of COVID has it been needed more to have access to really high quality online education. The University of Warwick needs absolutely no introduction. 8th in the United Kingdom, ranked 62nd in the world. They are a member of the Russell Group of universities in the United Kingdom, and that is the top universities in the UK which have a particular focus on research output and the quality of research, and ensuring that, I think the most common phrase we've used this evening is the evidence base, ensuring that, we're constantly adding to the evidence base in each discipline. Warwick has an incredible reputation and depth of experience in diabetes education. You can see there, over 14,000 graduates over the last, I think, 15 to 20 years. So, absolutely, certainly in European circles, when you think of diabetes education, you think of Warwick. This program, as we said, was specifically developed to be an online interprofessional offering. It is, however, to the exact same standard and quality of any other program that Warwick have. It's a level 7 program on the UK framework, so it's at master's level, and the award that you get is a master's degree or a postgraduate diploma degree from the University of Warwick, the exact same as any other that you get. So in terms of actually what the offering is, so it's a master's qualification, which is chunked into 2 pieces. There's a 12-month postgraduate diploma and then a 10-month master's module. It's recognized locally in Australia, so you will get your CPD credit for going on the program. And I think, the platform will show you in a little while, but the faculty that we have on the program are, and this is a selection of 5 of about 30 people that are involved in running the program. Diarmuid Quinlan is the National Diabetes Lead in Ireland. Pam Brown is on the NICE Guidelines Steering Committee. Colin is a examiner with the RCGP, and I think it's now the Primary Care Diabetes Society in the UK. It's almost by exception that the committee members are not involved in this program. And then we've got people like Ralph, who's the president of the Diabetes Society in the UK, in Australia, and Letchaman Ramanathan, who is a predominant endocrinologist in Malaysia. The depth of expertise of the faculty is immense, and the benefit, as Rebecca said, of that international perspective is absolutely huge. I think so. The average age on our programs sways between late 30s and early 40s, and majority of people are involved in either in primary care or in managing diabetes in secondary care settings. Therefore, the type of person we have is a busy clinician, and they often have small families as well, just given the age profile. We think it's really important that the program is structured to be supportive, to be flexible, and to enable you to do it alongside all of your other commitments. So I suppose the first thing is we put a limit on group sizes, and we put a limit on numbers, and we maintain, so Kenny, who was speaking to us a few minutes ago, is in a group of 20. He knows that group incredibly well. He knows his tutors incredibly well. It's done as small, all the benefits of small group teaching. The module structure of, 6-week modules in the postgraduate diploma, and then you move on to do your professional project. That pace works extremely well. It's it's quick enough that you're getting through it in a short time frame relative to some other offerings, but it's not too quick that it's overwhelming. And I think the message we keep on getting back time and time again is that people are managing to do this program with their clinical workload, with their other clinical commitments, and with their family commitments. And that's underpinned by a huge level of support. It is support from the tutors, it's support from the program management team. You will see somebody from the program management team on each and every one of your weekly tutorials. So, there's always somebody to ask questions to, there's always someone there to address issues if they arise and to give support. And, I am continually bowled over by the fact that we've had so many people complete this program successfully during a pandemic. It speaks to their commitment, but it also speaks to the program having the right structures in place. So in terms of how it is structured, so we start off, each of these represents a 6-week module, and we start off with core principles. So understanding, why the epidemiology of diabetes is important, and very much then looking at, finding and classifying our patients. So diagnosis, screening, pre-diabetes, if that's still an okay term, and then classifying them, etc. We then look at issues around, it's as is the case in most populations, there's an awful lot in Australia that would suggest that self-management of diabetes and lifestyle change and diet and exercise can play a really important part in managing the condition with people. And you as a clinician having an evidence-based toolkit to draw from to be able to influence and support and motivate your patients is critical. So the self-management module deals with, behavior change, motivational interviewing, and areas like that, and really giving your patient a sense of ownership and responsibility and empowerment over their condition. And as Kenny said, you're not someone who is diabetic. You have a range of complications that you need to manage. We then, irrespective of your scope of practice or what is allowed, we teach you the entire treatment range within diabetes. It is constantly changing. Stephen and I would joke that 6 months is a long time in the evolution of treatment in diabetes. More and more treatment is being pushed down, from specialists into primary care, from doctors to nurses. That is evolving all the time. So we bring you through the entire range of treatment options available. And that makes up a very coherent first semester of the program. So you've got 3 6-week modules. The second semester then, we get into the heart of what Stephen was talking about a few minutes ago, managing complications. So, and we spend a week looking at each of the major systems and how diabetes affects it, how we can mitigate its impact on those systems, and prevention being a key goal here. How can we stop end organ failure? How can we how can we slow down the onset of things like retinopathy, etc. And then the 6th module is fascinating. It is it's looking at very topical issues like gestational diabetes, like the links between diabetes and mental health. We are fortunately seeing people with diabetes living longer and longer, which then leads to comorbidities with other issues. We've got issues around fasting, and what do you do if you're doing something that's physically endurance testing? If you're when we used to be able to travel 6 hours east or west, and what impact that might have, how that impacts on diabetes. So what you can see from across semester 1 and semester 2, we're taking a really patient orientation look at diabetes, and we're giving you a huge level of confidence to manage a patient population. And what our alumni constantly tell us is, they become the go-to person for diabetes in their clinic or in their area, and they seek out the complex and challenging individuals and really try to support them. When we move into the 3rd semester, then this is all about application and research. So you choose an area of diabetes that is of interest to you, where you see a gap in the literature, and you conduct a professional project in that area. And we have some absolutely fascinating projects from our students, looking at basic things like the impact of registries right up to designing clinical trials as protocol papers. And it really, there's a huge breadth of what you can do as a professional project, but the base principles of it will always be designing a piece of research and then conducting it. We separate this 10-month module into 2 sections. One is a taught component, where you design out your project, and then you work with your supervisor to conduct that. And I think Warwick's method of assessment is as contemporary as you can get. We're not going to ask you to do a 10 or 15,000 word thesis. We're going to ask you to produce a journal article, and we will ask you to produce a conference poster that is ready for presentation, and then present that to us. So at the end of your program, you get something that is of genuine utility to you and interest, and hopefully can give back to the body of knowledge in diabetes. So in terms of actually how it works, we'll start off with a really comprehensive online orientation. Similar to Kenny, most people in the program will not have been in any sort of academic program for many years, and they likely won't have done an online program. So we make sure you're comfortable with the structure, with the supports, with the regulations, with how to use the online environment, with where to ask for help if you need it, and really make sure that before you actually start week one, that you are really, really comfortable. We then get into a rhythm across each week. So each week we'll start with a discussion forum post where we'll give you a clinical case, and we'll ask you, your thoughts on the next steps in, diagnosis or treatment, etc. And you'll contribute to that in your own time. It's an online discussion forum that you just contribute to as and when you want during the week. Most of your time during the week is going to be spent on the online platform, and what we have designed is some of the highest quality e-learning content that you're going to see. It's full of video submissions, it's full of interactivities, but I think most of all, it's got really, really representative patient cases. So we will bring you through the background and theory of everything of a particular topic that week, and we will then ask you how you would put it into practice. What decisions would you make? And then towards the end of the week, once you've contributed to your discussion and gone through your content, you'll then come on to the online tutorial, and that's a once a week meeting, usually on a Thursday evening in Australia. And that very much sorry, there's just noise coming in. I don't know if everyone else is coming as well. I'm finding it hard to hear. Oh, it's gone. So that weekly tutorial very much brings the content to life. It's you could be with Stephen or one of the other tutors in your group of 20, and you're having a very practical case-based discussion as to why does the evidence suggest we do things in a particular way, and how do we implement this? Is it challenging? How do you bring a patient on that particular journey? So that rhythm each week of having a discussion, going through the content, and then attending your tutorial, there's a lot of flexibility in it. The tutorials are all recorded, they're all available to watch afterwards, and it allows you to manage this program with all of your other family and work commitments. The assessment then is, I think, fair is probably the word I would use to describe the assessment. You have an essay at the end of each module. So, at the end of module 1, you will do an essay which will review the literature on screening or diagnosis of diabetes, and ask you then, how would you implement this in your own clinical setting? So, what the assessment is always going to do is ask you to understand the literature, to critique it, and then say, well, what does this mean for me? What does this mean for my practice? There is a knowledge-based exam at the end of each semester, and that is, single best answer, multiple choice style exam questions. The assessment in the program is not something to generally be concerned about. We have extraordinarily high pass rates, and that is a factor of really well qualified people coming onto a program that get a very positive experience with an amazing faculty, and then have a fair assessment. So, we expect people on the program to come on and to do well. And you can see some of the statistics here. We've had over 500 people on the program over the last 3 years. we've got really, really high engagement levels. And again, this shows to me that it's designed well. It's designed so that you can manage it with your workload. And the pass rates, those pass rates are extremely strong. Most people that start this program get through it and get through it well. In terms of some of the things Kenny was talking about of confidence levels, we ask people as they come onto the program and as they exit the program what their confidence levels in various aspects of diabetes care are, and you can see the I suppose the guidelines based ones, like prescribing for cardiovascular risk prevention. People just know how to do that. They are extraordinarily confident. They're confident on injectables. What they still have challenges with, overcoming obesity or recognizing the stress, some of the emotional aspects and the psychological aspects, they remain challenging. But you can see there's a huge jump in confidence levels around lots of areas of diabetes management. But aside from that, and this is the group that finished in 2017. We went back to them last year and said, right, you're qualified 3 years ago. In retrospect, what did this qualification do for you? And you can see there patient care, impact on their career, reputation with colleagues, and that's the one that comes up anecdotally time and time again, that they become the go-to person for diabetes, or they end up managing a specific diabetes clinic. And as Kenny spoke about, your understanding of research and the evidence base behind diabetes is key. So I'll just go into the entry requirements then, because that's usually one of the questions that people have. So the first thing is we will look for evidence of proficiency in the English language. That is not an IELTS test or a Cambridge test. We get that through your personal statements, and we get that through conversation with you and the recruitment team as you come on board. We do need you to be employed clinically. It's a very applied program. If you're not seeing patients with diabetes, and that can be as a dietitian, as a pharmacist, as a nurse, as a doctor, it can be in primary care or secondary care, that doesn't matter. But you do need to be able to put the program into context and put what is a very patient-oriented program to see how it would apply in your clinical setting. The base then is, a 2-2 honours degree in a health science, and again, that can be anything from nutrition and dietetics to medicine. What we will ask you for in the application process then is a copy of your degree transcript, your personal statements as to why you want to come onto the program, how you feel it is a good fit for you and you for it. We'll ask you to give us a short letter just to say that you're a clinical professional in good standing, and that can either be from an employer or a previous academic, and we'll ask you for photo ID. This program, I spoke about the cohort size of about 20 students per group. It is limited, and the places do sell out every single time we run the program. So if you are interested, the advice is always to apply early. In terms of fees, the fee structure is split between either if you're doing the Master of Science or if you're doing the postgraduate diploma. You can avail of what are reasonably high discounts if you register before the end of the month, and if you register and pay before the end of the month, there is a higher one again. So you can see the fees there. It's 12,000 or 8,000 for the Master's Diploma, but if you register before the end of this month, there's a sizable reduction on those. When it comes to paying, you can pay either by semester or you can pay by monthly installments. So there's a lot of flexibility in how you can pay your fees. But I suppose sitting here on the 13th of July, I would stress these reductions. There are a couple of weeks left to get those. So if you want to apply and get those reductions, the advice is obviously to do so. So I'll move on to questions in a second, but just to summarize, it's a 22-month master's program made up 12 months of a PG diploma and 10 months of the MSc. The next intake is in October. We do have limited places. If it fills every time, we will have a group from Asia Pacific, we'll have a group from the Middle East, we'll have a group from Europe. Warwick is a phenomenal institution to study with. It will look amazing on your CV. They have a strategic alliance with Monash in Australia. It's recognized everywhere. What I also hope you got from the start of the call with Kenny and Stephen and myself is it's a formal program. The assessment is taken very seriously, but it is delivered by a bunch of really, really open, friendly, accessible people who are passionate about diabetes and passionate about education. And it's a very inclusive and open program to study on. So, it is, in as much as an academic endeavor can be, it is actually fun. It's enjoyable. I think I'll stop sharing here. I think the weekly tutorials for me, Stephen, are the absolute highlight. That you're bringing your group together, you're having conversation on whatever the week's topic is, and really getting good debate going. So, sorry, Stephen, do you want to come in there?
Yes, absolutely. I was going to say, Dermot, that the brief demonstration talk that I gave just a few minutes ago doesn't really demonstrate as well the actual experience that you have when you are with the tutor, because there is some kind of cohesion that develops within a group when you are coming together on a weekly basis. You get to know your tutor, people relax in terms of asking questions, and it really is the opportunity that you have to iron out any concerns or worries that you may have about the course itself. So it's not just around the dissemination of information, it's an opportunity to actually discuss any worries or concerns you have around the upcoming academic assignments, and everything is all directed towards ensuring that you actually get through and over all of those hurdles.
Yeah, I think it's very valid, Stephen. I think everything in the program is designed to help people succeed. There's no hurdles that are placed in people's way. I think the other piece that I keep focusing on is that cohesion, that group support. I think is incredibly strong. So, Rebecca, is there anything on chat coming in terms of questions, or have we?
No, everybody's extremely quiet today for a change. So there's no major questions coming in. So they seem to, hopefully we've answered the questions during the session itself. So I think, I think for once we're finishing on time. So I think that's actually a record for us. But I think we'll send, just to let you know, we will send out a recording of this session to everybody on the who has participated and attended today. It'll be in your inbox tomorrow, and there will be an apply now and pay deposit on that email as well. As Dermot said, just because it is online, it does not mean we enroll without any discretion. We do cap the numbers per region, per intake, and they are filling fast. So you're enroll now, you apply now, and pay deposit buttons will be in the email. And our education advisors will be reaching out to you by phone if you have any additional questions whatsoever.
Thanks so much, Rebecca. And Stephen, thank you for everything this morning or this evening.
Thanks again, Stephen.
Thank you. Thank you.
Likewise to Kenny earlier. Thanks a million, everyone.
Take care, guys.
Bye. Bye. Bye.